I'd like to welcome everyone to the AO Journal Club on femoral shaft fractures. So without further ado, we'll start with the first interview. Dr. Bone, thanks for joining us.
You're welcome.
Go through your experience dealing with femur fractures and how things were dealt with before your paper came out.
The paper came out in '89, and we did the study in Dallas between 1985 and '86. But I started getting interested in femur fractures, and especially femur fractures in the multiply injured patient in the early '70s, when I was a general surgical resident in Buffalo, New York, and was mentored by John Border. Dr. Border was a general surgeon who treated the multiply injured patient, but he also managed fractures as the general surgical department alternated fracture call with the orthopedic department. In the 70s, the standard management of a femur fracture was to put them in skeletal traction. Standard time was about 7 to 10 days, because they felt that if they waited 7 to 10 days, they felt that they healed quicker. So everybody with a femur fracture, whether it was isolated or multiple trauma, got skeletal traction. There was a reasonably high incidence of what we call fat emboli syndrome. There were some papers that came out of Europe in the mid 70s showing that if you did early stabilization of the femur fracture in a multiply injured patient, you could significantly reduce the fat emboli syndrome complication. The most famous one was from Helsinki, Finland, by a doctor named Riska, who reduced the fat emboli complication from 22% to 2.5% by doing early stabilization. But Dr. Border believed in it, and we started doing early stabilization in the mid to late 70s. This was not standard treatment, however, and when I went to Dallas to do an orthopedic residency in 1983, Ken Johnson was an attending, did a fellowship with Ted Hansen at Harborview. Ted was the only other person that I know of in the 70s that was treating the multiply injured patient with femur fractures in an early stabilization. Ted and John hadn't connected yet, but they believed in the same principle. The study came about when Ken asked me to sit on a panel of a grand rounds in the general surgical department on fat emboli syndrome. During that panel, I told them that in Buffalo, we treated femur fractures early and significantly reduced the pulmonary complications. They thought I was crazy. They absolutely didn't believe that femur fractures or that orthopedic injuries had anything to do with the complications of the multiply injured patient. General surgical departments were, quote, the captains of the ship, and they dictated to orthopedic departments when they could treat the fractures. So when I sat with Ken after that symposium, we decided we needed to do a prospective and randomized study that early stabilization made a difference in the multiply injured patient. What we worried about, however, is that because of our bias, that early stabilization was important, we could be criticized. So we asked John Weigel, who was a young trauma surgeon in the general surgical department, to be part of the study. He didn't believe femur fractures were important to be treated early. And so he could be our control. I have to tell you about the randomization, because randomization wasn't, there weren't very many orthopedic papers out there that did prospective randomized studies in 1985. Yeah. And I wasn't really sure how to randomize them. So I took pieces of paper and I wrote early and late on each one. I mean, individually. And I wrote 100 of those out, and I put them in a shoebox and shuffled them up, and then pulled them out one at a time, put them in an envelope that were labeled 1 to 100, and tacked them on the on the bulletin board in the emergency room. And that was my randomization. It might not have been scientific by today's standard, but it was definitely randomized.
So this is kind of a classic. We have an idea, we think this works, and now we have to prove it, and that's where this study came from.
Right. There was retrospective evidence coming out of Europe that early stabilization was important. And we knew the difference because we had lived the difference. I can give you an example. When I was a general surgical resident in Buffalo with John Border, we alternated fracture call every other night with the orthopedic department. We were doing early stabilization. We were plating femurs in those days as per the AO philosophy. And the orthopedic department was putting them in traction, which was standard care. And in the emergency room, John could document the difference between their patients and our patients. So we knew it made a difference, but we had to show the world that it made a difference.
And I'm seeing in frequent, in like review books that this article, they cite your article saying this changed people's minds, this changed people's mindsets.
It did. At the time, it was the best we could do. And it did. It absolutely changed the way orthopedic injuries were managed. I've taught all over the world for 30 years. I smile on my face when I remember back giving a course in polytrauma in Switzerland. And one of the faculty was a orthopedic surgeon from Britain. And he told me that when that paper came out, he used to put it in his back pocket and walk around. And every time a polytrauma patient came to the emergency room, he would show that paper to the general surgeon and the anesthesiologist and say, "See, we got to do this." It was the proof. It was the proof people needed, yeah. Especially if there were doubters in their hospitals, and really there were.
After this is done, right? How did it change? How did you see it change? Did the orthopedic surgeon now become the decision maker as far as stabilization, or was the general surgeon in charge still?
The general surgeons are always in charge, but we became much more of a collaborative team. Orthopedists now had the evidence and developed a protocol for managing the multiply injured patient. Vast majority of polytrauma patients could have their femur fractures treated, stabilized safely. That's what we wanted to stress. One of the important parts of the Buffalo experience was that because we were the orthopedic surgeons as well as the general surgeons, we didn't have to fight. We just went in and did what we felt was the right way of managing it, and then showed the results.
Based on this, something you mentioned is, if someone's too sick initially, but ongoing resuscitation doesn't mean you got to wait another 24 hours until their labs improve, and then still being aggressive, getting them fixed early. Right.
An excellent question, because that's the way we managed them in Buffalo. You do not want to take to nail that femur in a patient who's not stable. But the idea that they're not stable now, but 6 hours from now they can be stable, and you can go ahead and nail them. Time period around 48 to 72 hours, that it is not a good time. But if you can get them within the first 24 hours, yeah. Even if it's not immediate, even if they've been coagulopathic, and I don't know if I coined the word, but I use it. It's resuscitate them. The general surgeons take them and they do their surgery, and now they need resuscitation again as if they were freshly injured, and then you get their parameters controlled and stabilized, and then you can go and take them back. And we've done that routinely. The concept of too sick has changed. We can make them better. The old days was, oh, they're too sick, we got to wait and until they get better, but they never got better. They were put in skeletal traction. They were in this forced supine position. ARDS developed, and we never got to them because they died. too sick was a bad concept. They're not ready, but we can make them ready, and do them at an appropriate time. The concept of damage control, which came out in the early 90s out of Hanover, Germany, that's a whole different story. And I think I had to fight back on that concept because their idea was, well, they're too sick, we're just going to put them in we're just going to put an X fix on them. That was certainly better than skeletal traction. Still forced them to into a forced supine position that we know is damaging. But there is a place for damage control. There certainly are patients that come in so sick, and it's better to stabilize them with X fixes and get them give them the ability to be mobilized than to put them in skeletal traction. I fought against damage control because I was afraid when it came out that it was going to be an excuse for the orthopedic surgeon to not operate. I gave a John Border talk at the OTA some years ago, and I pushed very hard against that because it's not your convenience, it's what's best for the patient. In 30 years of managing multiply injured patients, I can only count on one hand how many times I had to do damage control. Many of these polytrauma patients in those days were not adequately resuscitated, and so they never got stable enough to be stabilized. In today's world, if we can't get a patient stable, then they're really in trouble.
This idea comes out of damage control, and then, like you said, it gets kind of propagated to the point where we'll just put them in an X fix and then you can ignore them. It's a continuum in finding that window when they're stable.
Right, and a good point is that all those lab values that we get are only a marker in that moment that they're going to change, and if you're changing them in a positive fashion, then it will become a time when, okay, they're good, let's go, let's stabilize them and do what is best for the patient at this time. If you never get to that point, then damage control is the next best option.
So one last point, we'll wrap it up with this, but so we have a stable window. The patient, the labs have trended in the right direction. Can you kind of give your approach if they're critically injured?
Right. The approach is with the least amount of blood loss that you can. So you only ream to get a nail in that will stabilize them. It's so much better than the old days where we had to ream to 18 to get a nail to be stable enough.
Wow.
Yeah, wow is right. But that's what we did. We reamed to 18 in order to get enough purchase on the nail in the medullary canal above and below the fracture site to control rotation. So yeah, it's and the concept of retrograde nails is for the femur was a great addition to our armamentarium because so many of those distal thirds could much more quickly be nailed. They could be nailed in supine position, which we can even now with the antegrade. But yeah, you don't want to waste time, and you don't want to bleed them any more than they've already bled. I would like to interject one thing here that I don't think got enough importance during the study. We randomized every femur, not just the polytrauma patients. So that an isolated femur fracture would be put in traction if they were randomized to late. And I want to remind everyone that late for our study was 72 hours. It was not 10 days.
Right.
Ken and I both knew that 10-day mark, we might have patients die on us. And so we wanted to make it long enough to make a difference, but not long enough to be harmful to the patient. We didn't lose any patients nobody died because we waited, but a lot of them got significant pulmonary complications because of the traction. But what I wanted to say is the isolated femur fracture, we followed their blood gases, and I can't remember now how often, but frequently. And if we saw young, healthy male patients with an isolated femur fracture drop their PO2 sats from 90 to 60 routinely just by being in traction in bed. And if you were to put that on top of a pulmonary contusion or multiple rib fractures, it doesn't take too much to extrapolate. Yeah, that's why they get ARDS. That position was so detrimental to your capacity to oxygenate that it was a really bad concept.